Welcome to the first of our videos explaining how the FaceIT at Home programme was designed and created, with me, Dr. Ali Norman from the University of Plymouth.
Back in 2004, the Centre for Appearance Research and Changing Faces were talking about the need for intervening for people with visible difference. People with visible difference can experience high levels of anxiety, as well as lots of social difficulties around staring, name calling and unsolicited questioning. And within the UK, there is very limited intervention available for individuals that are experiencing such distress. So the groups thought that it would be really important to try and set up some kind of intervention that would be more easily accessible for potential service users. So some of the things that they identified, and then we went on to identify in the wider project of FaceIT, was that there really were very minimal interventions within the UK, and I'll talk a little bit more about that in a moment. And where there were different bits of services, they tended to be based in large towns and cities in the UK, which meant that if you lived in more rural areas, there were very limited amounts of support. And having to travel long distances was particularly problematic for those individuals who may also have physical disabilities associated with their visible difference, and particularly those that experience high levels of social anxiety. Expecting them then to take long journeys, potentially on public transport, was very prohibitive. The final thing that was identified was that there was a real sense of stigma for people around accessing therapy. Individuals quite often felt that they were potentially viewed as vain in some way if they sought support. So the idea was to try and come up with something that would be a little bit more available, accessible to individuals, and also something that could then remove some of that stigma associated with the therapeutic approach. So if we look at the model here, this outlines the different types of level of intervention that may be possible to provide to individuals. So we have at the very top here, level 1. So this is looking at minimal or mild levels of distress. So individuals that are generally coping okay, but have perhaps some psychological need. And for those groups, we would want to be providing some kind of information service, maybe leaflet, something online, and possibly some kind of telephone support service. And these are the sorts of things that Changing Faces generally tend to provide and have done for many years. We then have the level 2, which is for individuals with slightly more psychosocial need, but are still perhaps coping reasonably well. And again, some of the stuff from level 1 might fit in here, but we may also want to extend the provision out to things like self-help materials, or maybe even sort of peer support groups, either online or face-to-face. We then have level 3, which is looking at more moderate levels of distress, and some of the skills workshops that are available both in the UK and internationally would fit within this level 3 framework, but also things like online CBT, but potentially administered with some kind of facilitation or support from a healthcare professional, and also things like support groups that are led by health professionals rather than peer support. And then at levels 4 and 5, we have more tailored specific support, which would be more like your standard one-to-one therapies that would be available to individuals, with level 5 being ones that are integrated within multidisciplinary teams, and within the UK that would sit within the NHS. So this is looking at the model in a similar kind of way, except to look at how we would envisage numbers to be at each of these different levels. So at the very bottom layer here, levels 0 and 1, we would expect there to be a potentially high level of requirement for those sorts of information resources. And then the numbers of individuals that were likely to need access to those kinds of interventions is going to decrease as we move up the hierarchy. And additionally, we would expect that the level of intervention would go down from level 5 through to level 1, where there'd be minimal support. And what we want to do is create interventions that fit at each of these different levels so that we can provide people with tailored support to their needs. And the idea is that we would triage people then so that we could work out what the most appropriate form of support would be to their needs, and also taking into account their personal preferences as well. So, for example, a triage system may identify that somebody needs a level 4 support, but they may not feel ready to attend therapy with a specialist. So actually maybe offering them something at level 2 where they do some bits and pieces of self-help at home may just improve their confidence enough that they're then prepared to integrate with some other form of intervention. So this is the model that we have been using with the FaceIT campaign to try and identify where we can plug the gaps within that intervention framework. So to talk about the FaceIT, the adult FaceIT programme, I started working on this project as part of my PhD. So the Centre for Appearance Research and Changing Faces got together and provided some funding for a PhD student, and I started that process in 2005. I should say that my surname was previously Bessel, so you can see these references here. This is me. And the first thing that I did on my PhD was doing a systematic review of existing interventions. So looking to see what was already out there and what was needed, but also trying to get a sense of what worked and for whom. What we identified from that review is that, unfortunately, there's very limited evidence for the effectiveness of interventions within the appearance field. But that what little evidence there was suggested that a combined social skills approach with cognitive behavioural therapy seemed to be the most effective form of treatment. However, because there was limited amount of papers, there were only initially 12 papers in the original systematic review. The next part of the PhD process was to do a needs assessment. So this was going and talking to service users about what kinds of things they found useful themselves from having gone through a therapeutic process, but also asking those individuals who felt that they could do with psychological support but hadn't accessed services, why they hadn't accessed it and what would help to make it more attractive to them. And from that process, we were able to then produce a basic framework, a template for the kind of program that we thought the FaceIT should encompass. The third stage then involved extensive usability assessment and beta testing of the program. So this was using a form of action research approach. So what we did is we created a prototype of the program. We asked potential service users and health professionals to then view that particular prototype, and we had interviews or focus groups with those individuals to talk about what they liked and what they didn't like. We then went away and made further iterations to the prototype, and then went through that process again. And we went through 4 different stages of this until we produced a program that was workable and seemed to be usable for service users. And at that point, we put the final prototype into a randomized control trial to assess its effectiveness and its acceptability.
Thank you for listening to this video. In the next video, we're going to be looking at the program design of the original FaceIT program, and then after that we're going to move on to describe the process of actually assessing and testing it with a user population.